Today we will learn about the urinary bladder. Urinary bladder. It is an organ entitled for the storage of urine, which is the continuation above the ureter and below the urethra. It lies in the lesser pelvis, behind the pubic symphysis, and in front of the rectum in male, and in front of the uterus in female. Urinary bladder is size and shape. Size and shape varies with the age as well as the amount of urine. Its size it is tetrahedral. Tetrahedral when it is emptied, and it is ovoid when it is full. Shape and size is the senses of for the maturation. The normal capacity is about 220 ml. 220 ml, and when it the senses start after 150 ml, and it become painful after 500 when it reaches 500 ml. Okay, and 800 ml, 800 to 1000 is about to rupture. Okay, now it is a pelvic organ in the adult, whereas in the children it is abdominopelvic, and when it distended, it becomes an abdominal organ in children. Okay, now coming to its external feature, it has got one apex. This is one apex. Then it has got this is apex. This one is the posterior surface or the back. This is superior surface, and here and again on this side, that side, it is the inferolateral surface. This one is inferolateral surface on the left side, and this inferolateral surface on the right side, and this is the apex. It's just like head of a head of a cow, and this is the nose like this, and this is the fundus or the posterior surface or the base of the bladder. This is superior surface, this is inferolateral, and this is the neck. Here is the neck of bladder, where from the urethra start. Okay, now it lies behind the pubic symphysis, and in male in front of the rectum, and in female in front of the uterus. In front of the uterus in female. Okay, and now again the relation more promptly. There is anteriorly there is horseshoe shaped, the space of Regius. Space of Regius, it is a horseshoe shaped space in the right side, in the left side as well, which is bounded superiorly by the peritoneal fold, and which lines the abdominopelvic cavity, but only up to the greater pelvis. It lies in the lesser pelvis. This is the continuation of the peritoneum of the abdominal cavity. So there is superiorly there is peritoneal fold. Okay, and medially there is, this is one Regius space, and this is one. Superiorly, there is peritoneal fold forming the paravesical fossa, this side and this side as well. And anteriorly, there is pubic symphysis and the body of pubis. The laterally, there is fossa covering the levator ani and the obturator internus. And medially, there is inferolateral surface of the, this is the inferolateral surface of the urinary bladder, medially. And below, there is, here is in male, here is the site of the prostate. So puboprostatic ligament lies here, or in case of female, there is pubovesical ligament. So space of radius, it is horseshoe-shaped, and we can count it on the both side. And anteriorly, there is pubic symphysis at the body of pubis. Posteriorly, there is the posteriorly, it is continuous behind it. That there is posteriorly, there is posterior true ligament of the urinary bladder. And later we will discuss the ligaments of the bladder, in which there is posterior true ligament of the bladder. So posterior true ligament the bladder, laterally fossa covering the obturator internus and the levator ani, superiorly the peritoneal fold of the abdominal cavity forming the paravesical fossa above, and the medially there is inferolateral surface. This is the space of radius. Okay, so the apex of the bladder is in relation with the here is the pubic symphysis and the space of radius and the retropubic fat. Inferolateral surface in relation both sides, the space of radius again, because it is horseshoe-shaped, it is anteriorly as well as the laterally. So and the laterally, it is, that area is non-peritoneal, because peritoneum is covering above, here above, because the peritoneum covers from the, that is the anterior surface of the rectum, then it is coming the post-vaginal fornices, then coming over the uterus, and then reflect over the superior surface of the urinary bladder, and then they are forming the different fold, that is the median ligament and the medial ligament, medial umbilical ligament, like this. So the on the lateral surface there is a space of radius as well, and that is non-peritoneal area. Okay, and the superiorly there is peritoneal fold, as I stated earlier. So on the superior surface relation there is also sigmoid colon. Okay, the sigmoid colon here, and the coils of a small intestine as well. And the on the posterior aspect, suppose this is the posterior surface of the bladder, there is a seminal vesicle on the lateral side, and the medially there is vas deferens. Okay, this is vas deferens, which is coming from the testis. This is the testis, and here is the, on the posterior lateral aspect, this is the epididymis, and this is the vas deferens, is coming here medially on both sides. This is the vas deferens. Here is the ampulla of the vas deferens, and on the laterally there is a seminal vesicle, and both unite to form the ejaculatory duct, which opens into the prostatic urethra. Okay, so on the posterior aspect, what is the relation? There is seminal vesicle and the vas deferens. And above, suppose posterior surface, this is the posterior surface, and it can be divided into posterior surface upper part, upper 1/4, and the below 3/4. The upper 1/4 there is a peritoneal fold. This is the peritoneal fold above, and the coils of a small intestine is there, coils of a small intestine. Okay, and that is peritoneal area, and below there is on the lateral side there is seminal vesicle, and this is the vas deferens and the seminal vesicle. Okay, and there is also in between the vas deferens there is the fossa of denuncular, that is the rectovesical. In between this is, suppose this is the rectum and this is the urinary bladder. In between this is rectovesical pouch. Rectovesical pouch, the ampulla of the rectum. Here is it ampulla of the rectum. This is rectovesical pouch. It obliterate below and forms the rectovesical fossa or the fossa of Denenwiller, which acts as a tendon of grace of God, because it restricts the infection from the rectum to the urinary bladder. Okay, or from the urinary bladder to the rectum. The carcinoma spread. So the posterior relations are like this. And now on the inferolateral surface, we have already told that is the non-peritoneal area. And then in the neck of the bladder, there is, in the male there is prostate, and in the female there is urogenital diaphragm. Okay, urogenital diaphragm, which is made up of sphincter urethra and the deep transverse perineal muscle. And posterior हो गया, inferolateral, superior हो गया, apex हो गया. So these are the relation, and I have already told about the space of Retzius. Now coming to the ligament. This is the external feature. Now coming to the internal feature, this, and now external feature, it has got also border, anterior border. This is the anterior border. Like this. This is the anterior border. Okay, which starts from the apex and going up to the urethral orifice. Okay, this is the anterior border, and this is posterior border, which is in between the two ureter. This is posterior border, and this is the two lateral border, which extends from the apex and going to the ureter of their respective side. This is the lateral border. And angle is the anterior angle, and this is the posterior angle, and this is inferior angle, where the neck of the bladder is there. Now coming to the ligaments of the internal structure of the bladder. Suppose this is the posterior surface of the bladder, and here is the site of ureter. Okay, ureter traverses has also got intramural course inside the bladder wall. This is the intramural course, which creates a urethral fold over there. And this is urethral fold, and here is the opening of the ureteric opening, and there is a continuation of the longitudinal muscle, inner longitudinal muscle, with the bladder wall, and then again it is continuous with the longitudinal muscle of the another ureter. So this is called the bar of Mercier bar or interureteric bar. And again the longitudinal muscle cord, some fiber of the longitudinal muscle cord descend down towards the internal urethral orifice, and this is called the Bell's bar or ureterourethric bar. Okay, this is interureteric bar, and this is ureterourethric bar or Bell's bar, and this is Mercier bar. And just above the internal urethric orifice, there is a elevated part on the inner aspect, and this is created by the median lobe of the prostate. Median lobe of prostate in the male, and that is called the uvula vesicae. Okay, And regarding the histology, from inside outward, it is mucosa, the muscle layer, and the adventitia, mamma. And from inside outward, it is mucosa, and then muscle layer, and then adventitia. Mucosa, it contains the epithelium and lamina propria, and this is muscle layer. The epithelium is the transitional epithelium, in which there is CPU, not the CPU of the computer. It is the first there is the transitional epithelium is 4 to 5 layer thick, and the basal layer is cuboidal in nature, then pyramidal cells are there, and then umbilical cell. It stretches when distended, it stretches, and because there is a common, the fibrosepta is coming to the basement membrane from every cells. This is transitional epithelium. When it extends, it stretches, it becomes 2 to 3 layer, and when it shortens, when it is empty, then it forms a 5 to 6 layer thick. And this is umbrella cell, the above, that is binucleated cell, and above all there is glycocalyx, which wraps the luminal, which wraps the from the luminal aspect the urinary bladder and become permeable. It makes impermeable to the toxins present in the urinary bladder when the urine will not enter inside. Okay, and now about the muscle layer, it is made up of 3 layer. That is the inner longitudinal, in the middle there is circular, and then outer longitudinal again. Longitudinal, circular, and then longitudinal. Okay, but they are not in distinct pattern. They are interspersed, they are intermingling with each other. All the muscle layer, they are intermingling. Okay, in trabeculated pattern, not very much distinct. About a steady tree. And now above all there is adventitia, which is fibroelastic in nature. But here at this site, this is called the trigone, the triangular area in between the ureteric office and the internal urethral meatus. This is internal urethric opening. This is here the mucosa is very much adherent. In the rest of the urinary bladder, it is loose. Mucosa is loose over the muscle layer, and it gives a wavy appearance in everywhere. But here it is very much smooth mucosa, because mucosa is adherent to the muscle layer. Okay, and regarding this is about the histology. And one thing more, that the smooth muscle of the urinary bladder below is continuous with the smooth muscle of the prostate in the male, and in female it is continuous with the smooth muscle of the urogenital diaphragm. Very much important, and this factor adds to the fixation of the urinary bladder in its position. Very much important that smooth muscle is continuous. And regarding its development, the trigone, it is developed from the reabsorption of the mesonephric duct here. Mesonephric duct, they are derived from the intermediate mesoderm. So the trigone is derived from the intermediate mesoderm, which is formed by the reabsorption of the 2 mesonephric duct. And the rest of the part is, they are derived from the urogenital sinus, and which is derived from the cloaca, and cloaca is the lowermost part of the GIT. So it is of endodermal in nature, and this is mesodermal in nature from the intermediate mesoderm. And apex is the from the allantois diverticuli, developed from the proximal part of the allantois diverticula. Okay, and the rest of the musculature, that is the longitudinal circular, they are derived from the lateral plate mesoderm. Lateral plate splanchnic layer mesoderm. Okay. That is about the development. Now, and about the histology. Now coming to the clinical significance. First, the blood supply, it is supplied by the superior vesical artery and the inferior vesical artery, as well as the obturator artery, and in the female also vaginal and the uterine artery, and in the male also by the inferior gluteal artery. Okay. And now venous system do not follow the arterial system. It presents a venous plexus, and it in the male it mixes with the prostatic venous plexus, and here the vesical venous plexus lies in the posterior true ligament. Okay, posterior true ligament में vesical venous plexus होता है, which is going to the internal iliac vein, drain into the internal iliac vein via the vesical venous plexus, which lies in the posterior true ligament. Okay. Now about the external iliac lymph node. Okay. And I have not mentioned its support of the urinary bladder. It is the true and the false support. True and false support. True, this is, suppose this is the urinary bladder. Okay. This is the urinary bladder. And the true support is first by the, here is the median umbilical ligament, which is the which is formed by the urachus, the remnant of urachus. And then there are two puboprostatic ligament in the male and the pubovesical ligament in the female. In the right side there is medial and lateral puboprostatic ligament, and in the left side this is, and this is right side in the medial and the lateral puboprostatic ligament. Okay, and here is the lateral true ligament, and this is the posterior true ligament or sacrogenital ligament. Okay, posterior true ligament which carry the vesical venous plexus, and this is the lateral true ligament which arises from the inferolateral surface and going to the lateral pelvic wall, and this is from the posterior surface or base and going to the posterior pelvic wall, and this is from the prostate in the male and the lower neck of the urinary bladder to the pubic symphysis, pubovesical and the puboprostatic, and they are 4 in number. And this is the median umbilical ligament. This is the true ligament, and the false ligament is the fold of peritoneum over this. Suppose this is the here is this is the median umbilical ligament. The peritoneal fold over this is median umbilical fold. Then there is one medial. This is median, and there are 2 medial umbilical fold, which lie over the. This is over the urachus, and this is remnant of the umbilical artery, obliterated umbilical artery. This medial umbilical fold, and then again the lateral umbilical fold, peritoneal fold, which is the umbilical fold over the inferior epigastric artery, both sides. This is inferior epigastric artery. The peritoneal fold over that is called the lateral umbilical fold. This is medial umbilical fold on both sides, this one and this one, which is over the obliterated umbilical artery. Okay, and this is the peritoneal fold over the urachus is the median umbilical fold. We have to use word fold, okay, because these are the peritoneal fold. And this is the, and here And the posterior, there is posterior umbilical fold which lies over the posterior ligament, and also the this is rectovesical in the male, and the vesicouterine in the female. Vesicouterine pouch in the female, the peritoneal fold in between the uterus and the urinary bladder, and in the male in between the rectum and the urinary bladder, rectovesical pouch. And here is the lateral umbilical lateral fold. Now coming to the snuff supply, it has got sympathetic, parasympathetic, and the somatic supply. Okay, parasympathetic is by parasympathetic does what is the urination, it promotes urination. So the one thing I have mentioned, that is there are three muscular layer, that is the outer longitudinal, inner longitudinal, and the middle circular. They are all together known as detrusor muscle. When they intermingle with each other, they are known as the detrusor muscle. Okay, and the parasympathetic, it causes the contraction of the detrusor muscle and the relaxation of the internal urethral sphincter. Okay, so that the urine can evacuate, the parasympathetic action. And the sympathetic and parasympathetic is by the S2, S3, S4 spinal nerve. And this sympathetic is from the T11, T12, L1 and L2 from a spinal segment, and it causes the relaxation of the detrusor muscle and the contraction of the internal urethral sphincter, so that urine stores in the urinary bladder. It is an emergency system, there is no time to urinate. Okay, and this somatic nervous system, it supplies the pudendal nerve, that is also has got root value S2, S3, S4, but it supplies the external urethral sphincter, which is responsible for the voluntary control. Now coming to the clinical significance. Clinical significance is the first is the trabeculated bladder. Trabeculated bladder, when there is a neck, the obstruction of the neck of the urinary bladder, chronic obstruction, and then there will be cystitis, and there will be overloaded with the urine. The urinary bladder is overloaded and the muscle will hypertrophy, and that will give rise to the fasciculations. There will be hypertrophied bladder will result into the many fasciculation inside in the luminal aspect, and that is called the trabeculated bladder. Okay, and the second thing is the neurogenic bladder. Neurogenic bladder is of two types, that is the automatic bladder and autonomous bladder. Automatic bladder occur when there is upper motor neuron lesion occur, when there is lesion above the S2, S3, S4 level. S2, S3, S4 is mediating the local reflex system for the urinary bladder. They are getting the parasympathetic supply from there. So the upper motor, just above the level of the S2, S3, S4, the spinal cord injury occur. Then there is upper motor control lost. Then as it is only governed by the S2, S3, S4. When it becomes full, it automatically or reflexly evacuate. Okay, when it becomes full to a certain extent, then the local reflex comes from the S2, S3, S4 segment, and the person urinate. Okay, and that is called the automatic bladder. It is not under the upper center control. And another one is the autonomous bladder, in which there is a lesion of S2, S3, S4 level. Even the local system is paralyzed and not even the upper system. So that type of bladder has no sense to urinate. It only ये से भरता जाता है एंड दैट मच इट बिकम्स द ब्लैडर बिकम एटोनिक and the urine dribble all the time, and the and this is also known as atonic bladder or autonomous bladder. Okay, and one thing is suprapubic cystostomy, in which the prostate operation done, and also the calculus, urinary calculus in the urinary bladder, it is evacuated by this method, in which the urinary bladder this is the urinary bladder, it is covered by the peritoneal fold. It is when it becomes full up to the 300 to 500 ml of urine inside. If not, we have to distend, we have to give that much of amount of by injection that much amount of fluid inside the urinary bladder so that it can distend. And when it distend, it pushes the peritoneal fold upward and become very much close to the anti-abdominal wall. And then we do suprapubic cystostomy, which is done for the evacuation of the urinary bladder calculus and also for the prostatectomy by the urinary bladder route. Okay, so this is the clinical significance. And one is the regarding is congenital anomaly, that is the clinical significance related to its development, that we know that the apex of the urinary bladder, it is attached with the urachus, and urachus is going to the umbilicus. Okay, when the whole of this pathway after the birth, it become fibrotic. When it remain patent there is a connection between the urinary bladder and umbilicus, the urine will dribble all the time from the umbilicus. So this is known as urachal fistula. And when the proximal part and the distal part, this become fibrotic, and this only in the middle part it remain patent, this is known as urachal cyst. And when the distal part, that is the near the umbilicus, it remain patent, and this part become fibrotic, nearby the urinary bladder become fibrotic. This is known as urachal sinus. Okay, so this is all about the urinary bladder. Thank you.